I handed you 6 shoulder x-rays right now and asked you which ones were diagnostic, could you tell me why? As a clinical instructor, that's exactly the skill that I'm looking for. In this video, I'm going to walk you through a systematic approach to shoulder anatomy, positioning, and image analysis that will help you succeed in clinicals, practical exams, and the ARRT registry. Let's do a quick review of the shoulder anatomy. On the screen, you can see a couple different pictures. You have an anterior and a posterior view of the shoulder anatomy. On the left-hand side, you can see how the anatomy of the scapula looks compared to the posterior aspect. So when you're doing a shoulder x-ray, you want to make sure that you include the proximal 1/3 of the humerus, so about to here, but you also want to make sure that you include the entire scapula, which is seen here. So you want to include the inferior angle, superior angle, the acromion, the coracoid, and the entire scapula. This here is the medial border of the scapula and the lateral border of the scapula. The clavicle, which meets the sternum, and that forms the sternoclavicular joint. The acromion, which is seen here, that forms the AC joint or the acromion clavicular joint. And then the proximal humerus, this whole area here is the humeral head. And then this is the neck of the humerus, and then the body of the humerus. You're going to see the glenoid cavity seen here, and then also here posteriorly. The scapular spine and the scapular neck is seen from the posterior view. Again, you'll see the superior angle and the inferior angle of the scapula from the posterior aspect as well. Again, the glenoid cavity here, and then this portion here, again, is the posterior view of the clavicle. The acromion seen here, and then again, that forms the AC joint, the acromion clavicular, and then on this side, that's where the sternum will be found anteriorly. And again, make sure you're including the proximal 1/3 of the humerus. So make sure you know all of this anatomy when you go to take your boards or when you're studying for your registry exam. It's really important that you know all of the anatomy, both the anterior and posterior view, as well as what anatomy is needed for which particular views you're doing of the shoulder. Okay, so some information that you need to know for the shoulder projections. You're going to want to use a KVP between 65 to 70 KVP without a grid for an average size patient. If you are using a grid, it's usually for patients that have a thickness from anterior to posterior of greater than 10 centimeters. With those patients, you're going to use a KVP of 70 to 80 KVP. When you are using a grid, be mindful of possible grid cutoff as well. You're going to want to use a higher MA with shorter exposure times. If you're using AEC, you're going to want to center for the center of the cell for AEC, a SID of 40 to 44 inches. And depending on which projection you're going to do, you're going to want to use either crosswise or a vertical orientation. For instance, if you're doing an AP neutral, internal, external, or an axillary view, you're going to want to use a crosswise image receptor. If you're doing a grashey view or a Y view, you could get away with using a vertical orientation. X-rays can be taken with the patient either standing or supine. If you're doing obliques, you could do either posterior or anterior obliques. Typically, the images with the patient standing are more comfortable. However, just know you're going to have patients that come in that are trauma, that they have to be taken with them on the stretcher or with them on the x-ray table. So just make sure you're comfortable with how to get the shoulder x-rays, whether the patient is standing or laying flat. Also, make sure you are shielding the patient for these exams. Some additional information, make sure you are applying collimation for this. You don't want to use 14 by 17 completely open for these type of exams. Just collimate down to the anatomy that you need. Make sure you're including the soft tissue anatomy of the shoulder as well as the bones that you need. Accurate centering is essential because of how the image receptor reader scans the exposed image. You're going to make sure that you use proper exposure factors and ALARA principles. Again, ALARA means as low as reasonably achievable, so the lowest amount of radiation possible to obtain a diagnostic image. And pediatric patients, technologists may need assistance from the parent during the imaging exam to help prevent motion during the exam. If the parent is a female, make sure you are asking them if there is a possibility of them being pregnant. If they are, then you do not want that parent staying in the room. and make sure if they are staying in the room and they're not pregnant, say if it's the dad or the parent that's not pregnant, make sure that they have lead that they are wearing, in addition to making sure that the patient is shielded. Also, with pediatric patients, the KVP and the mask will need to be adjusted depending on the patient's size, and we will not be using a grid for shoulder x-rays for pediatric patients. So for an AP neutral shoulder radiograph should include, again, the proximal 1/3 of the humerus, the glenohumeral joint seen here, the coracoid process, which is this area here, the acromion of the scapula, as well as the lateral scapula, and again, the entire scapula within its entirety. So you're going to want to make sure that you have that inferior angle of the scapula in addition to the superior angle of the scapula, all within profile. And depending on the protocol where you work, you may be required to include the entire clavicle and the SC joint here. For the place where I work, that is our protocol. So just make sure that you know wherever you're working that whatever the protocol is, that you're including all of that needed anatomy for the radiologist to read it accurately. So a clinical instructor tip when you're doing a neutral shoulder, the patient's arm is going to be in a neutral position. So it's not going to be rotated in or out. It's just going to be resting on their side. And when it is in that position, neither one of the tubercles, the greater or the lesser, will be seen in profile. So if you see one tubercle perfectly, it's not in a true lateral position. So if you see more of the greater tubercle on this lateral aspect, then it's more of an external shoulder instead of an AP neutral. Make sure with this that you have the entire shoulder anatomy. We can see all of the bones and the detail here, and we can see all of the shoulder anatomy, but just make sure you're including a little bit more of that soft tissue anatomy as well. So again, the neutral shoulder is obtained with the patient's hand resting naturally against their side. The epicondyles will form approximately a 45-degree angle with the image receptor. Your central ray is going to be centered 1 inch inferior to the coracoid process. So the coracoid process is seen here. You're going to center about, again, 1 inch inferior, and that's going to be perpendicular to the image receptor. So some evaluation criteria, again, the greater tubercle is partially superimposed on the humeral head. The lesser tubercle will not be seen in profile. If it is, then it means that your hand is rotated, or the patient's hand is rotated in. The humeral head will be partially overlapping the glenoid. So let me show you that. So you can see that, see how it's partially overlapping the glenoid here. The coracoid process you'll see visualized, and the entire proximal humerus included. Exposure evaluation, make sure you see sharp cortical margins, visible trabecular detail, soft tissue visualization around the shoulder, and no burnout of the humeral head. So you want to make sure, again, you're using that KVP range between 65 to 70 without a grid and 75 to 80 if you are using a grid for the shoulder x-rays. For the AP external shoulder, you're going to have the patient with their back up against the wall bucky, or with them laying supine on their back on the x-ray imaging table. So with this, the image receptor is put in crosswise. This is going to be a 10x12. The patient is going to rotate their arm externally. You'll have a perpendicular angle, so a 40 to 44 inch SID. And then you're going to, here, that'll be the coracoid. You're going to center 1 inch inferior to that. Make sure you're including the SC joint, the entire clavicle, all of the anatomy, including the scapula, the inferior angle of that, and that you are putting your left marker, in this case, because it is the patient's left side, that you have the left marker seen in this area here and not in the patient's anatomy, and that you're including the soft tissue of the patient's anatomy here. And then again, make sure you are shielding the patient. With the patient's arm rotated out in an external rotation, that's going to be the anatomical position of the hand, and that's when you'll see the epicondyles parallel to the image receptor. So make sure for your boards, you're knowing the difference between parallel and perpendicular, and which one's parallel to the image receptor and which one's perpendicular to the central ray. So here's an example of the external shoulder. So again, this best demonstrates the greater tubercle fractures and rotator cuff insertions. So the anatomy demonstrated is the greater tubercle. You'll see this here on the lateral aspect of the shoulder. You'll see the humeral head, the glenohumeral joint space, which is seen here, and then the AC joint region. Again, depending on where you work, you may be required to include all of the clavicle and the SC joint in its entirety. Again, just make sure you know the protocol for where you work. And again, make sure you are including the entire scapula within the profile. So here is another view. So as far as evaluation criteria for a AP external shoulder, you want to make sure that you are seeing the greater tubercle on the lateral aspect of the shoulder. That shows you that the patient's arm was externally rotated. The lesser tubercle will be superimposed over the humeral head, and you'll see minimal distortion of the proximal humerus. The scapulohumeral articulation will be visible. And then as far as exposure evaluation, the cortical bone should appear well defined. Joint spaces should not be obscured by excessive density. So overall, looking at this image, first off, I don't know if this is a right or a left because it's not marked. If I'm looking at this, and I could assume that it is a right shoulder, but I don't want to assume, so you want to make sure that you are marking this anatomically correct. It is on the screen as if you were looking at the patient, which means this to me looks like a right shoulder. So you want to make sure that you're putting your right marker here in this corner out of the anatomy. To me, the overall image looks like it's positioned well. However, I would open up the collimation more to make sure I'm including that inferior angle of the scapula. And I would decrease the mass because overall to me, it looks like it is overexposed. So by decreasing the mass, it's going to help to highlight these areas more instead of having them burnt out. So you cannot see the edges. They're not really well defined. So I would make that correction to decrease the mass and then open up the collimation slightly to include that inferior angle of the scapula. Also make sure you're including that marker. So some common errors and fixes for the AP external shoulder. If the greater tubercle is not fully visualized laterally, that means that the arm is under-rotated. So you're going to want to do the image again with externally rotating the arm further, or as much as the patient can tolerate, until the epicondyles are parallel to the detector. Good to know, the external rotation means that the greater tubercle is out. So for the AP internal shoulder, this is obtained with the patient's hand internally rotated. The patient is supine, or they are standing with their back up against the board. And this is with a perpendicular angle, and their arm, the outside of their arm is out, and then the flat part here is resting on the side of their hip. So here you can tell that this is internally rotated because you can see the lesser tubercle in profile in this area. This is the glenoid cavity. Here you can see the soft tissue anatomy. Again, make sure that there is a marker and that this is oriented correctly. I would have opened this up just a little bit to include more of that SC joint if your facility requires that. And again, you're going to want to make sure that you center 1 inch inferior to the coracoid process, which is seen here. You're going to center about in this area. So the centering to me looks pretty good. They do have a right marker on here. I would just make sure that that marker is moved up out of the anatomy so it doesn't get in the way of any of the anatomy that is needed. So for this, you're going to want to make sure that you're directing 1 inch inferior to the coracoid process perpendicular to the image receptor. Some evaluation criteria for the AP internal shoulder. Again, you want to make sure that you're seeing the lesser tubercle demonstrated within profile medially. The greater tubercle will be superimposed over the humeral head because the arm is rotated in. If the proximal humerus looks similar to a light bulb, then you know that the patient's arm was rotated correctly. The proximal humerus is included without foreshortening, and then essentially this is a lateral view of the proximal humerus, and the lateral 2/3 of the clavicle and the upper scapula are seen. This is an additional image of the internal view of the shoulder. To me, this looks overexposed. This is really dark up here. There's no marker. And again, for our facility, we would do this in a crosswise view with the image receptor. I would see more of the clavicle. We're cutting the SC joint here, and then we're not seeing the centering is off for the scapula, so you're not seeing good KVP exposure. So you're pulling more of the KVP and the mass in this area. So I would bring the centering down, open up my collimation. So I'm seeing more of that anatomy and then more of the scapula in its entirety, and it will be centered better, which means the exposure values will be more of a diagnostic image quality. So for the AP internal shoulder, some common errors and fixes. If the lesser tubercle is not visible, again, you're going to want to increase the internal rotation and ensure that the epicondyles are perpendicular to the detector. So good to know, again, if the humeral head looks like a light bulb appearance, then you know that you have correct rotation for an internal shoulder. Exposure considerations, the humeral head trabecular markings are visible and the soft tissue margins are maintained. So when looking at this, how do you know whether it's internal, external, or a neutral view of the shoulder? Your main focus is going to be on the tubercles. Can you see the greater tubercle on the lateral aspect? No, so you know the arm is not externally rotated. Can you see the lesser tubercle in profile? Not really well. So their arm wasn't rotated in. This, to me, looks more like a neutral view of the shoulder. How do I know that? Because I cannot see the greater or lesser, one of them more well-defined than either one of them. So if that's the case, this would be a neutral view of the shoulder. So if your goal is to do an internal shoulder, then this particular image would not be acceptable for an internal shoulder. I would have the patient rotate their arm in as much as they can tolerate, and then I would also make sure I'm including more of this soft tissue anatomy in the shoulder x-ray projection. Okay, so the scapular Y projection is another one of the views that we often do in our department. So this is one of the most important trauma shoulder projections that you will see. A lot of times when the patients come in the department, if they have a dislocated shoulder, you will see the patient come in. They will have their arm resting on their side, and they'll usually have like their elbow up and they're holding their arm, holding their elbow. And then you can see an obvious like dislocation. Usually you can see that their arm will appear longer. That's usually a giveaway that they have a dislocation. So some of the anatomy demonstrated and what you should have demonstrated for a scapular Y view, you want to make sure that you are seeing the humeral head, which is seen here within the middle of the Y. So this Y is the scapula. So this part is the acromion, this is the coracoid, and then right down the middle is the body of the scapula, all the way down to this point right here, where that's the inferior angle of the scapula. So you want to make sure you see that in its entirety. When this is not overlapped over the ribs, then you know that you have the correct rotation. And when you see a true lateral of the scapula, then you know you have the correct rotation. This marker here should be up out of the way of the anatomy in this right-hand corner. So for this, you want the central ray perpendicular to the scapulohumeral joint, which is about 2 to 2.5 inches below the top of the shoulder, directed to the scapulohumeral joint region. So good to know is the humeral head will be demonstrated inferior to the coracoid, which is seen here. If there's anterior dislocation, if it is a posterior dislocation, you'll see this humeral head more underneath the acromion. The anterior dislocations are more common than the posterior, but just know either one of those can happen. If that's a question that's on your boards, just know the difference between the coracoid and the acromion, because if you see one more inferior, say to the acromion, make sure you know that that's more posterior. If it's more inferior to the coracoid, then it's an anterior dislocation. So some additional information about the scapular Y view. So the patient can be in a recumbent or an erect position, usually more comfortable for the patient with them standing. The projections can be done in both the anterior or posterior oblique position. For this one, the patient is rotated approximately 45 to 60 degrees into an anterior-posterior oblique position until the scapula is in a true lateral position. You're going to palpate the scapular borders to determine the correct rotation for a true lateral position of the scapula, and then slightly abduct the patient's arm slightly, if possible, so that it will not superimpose the proximal humerus over the ribs. You do not want to rotate the patient's arm. So if you're trying to get the Y view, or a Y view this way, you're essentially trying to get the scapula into a true lateral view. So this here. So like in this case, see how you can see the coracoid is here and the acromion is back here. So if you see the humeral head sitting more inferior, then this would be an example of a anterior dislocation. And then this looks like post-reduction. This is some evaluation criteria for the scapular view of the shoulder. So the scapula forms a symmetrical Y. So again, you're going to see this anatomy here. Again, make sure this is completely superimposed. If you have the arm more over the ribs, then that could indicate that it's over-rotated. You're going to make sure that you see the acromion and the coracoid that create the upper part of the Y. The scapular body is what forms the stem, and then the humeral head is centered over that junction of the Y. The scapular border should be sharp. The scapular spine, acromion, and the coracoid should be easily identified. And again, make sure this right marker is up out of the anatomy. So some common errors and fixes here. So under rotation, you have the scapular body is not lateral, so it's not rotated enough, and the Y appears distorted. So this here, you can tell that the patient is not rotated up enough because you're going to see this medial border of the scapula and the lateral border and the humeral head, and the proximal 1/3 of the humerus will be sitting more posteriorly. So in order to fix this, you're going to rotate the patient more towards the affected side. If you rotate the patient up too much, then the acromion and the coracoid are not symmetrical and the scapular borders are not superimposed. So you'll end up seeing more of the lateral border of the scapula and the posterior aspect of the scapula. And in order to fix that, you're going to rotate the patient slightly away from the detector. In this position, you may also see not only the lateral border of the scapula and the posterior aspect of the scapula, but you'll also see the proximal humerus over the rib area. That's usually a good indication that you've rotated the patient up too much. So here's an example of how the anatomy can change depending on the rotation of the patient. So from an AP position, if you rotate the patient between 35 to 45 degrees towards the board, you're going to see the grashey view in profile. When you are trying to get a Y view of the patient from an AP position, you're going to rotate the patient away from the board. If you don't rotate enough, you're not going to see the humeral head superimposed. Here you'll see the humeral head superimposed with the acromion and the coracoid in line with the humeral head. But then if you rotate too much, then that's where you see the posterior and the lateral aspect of the scapula in profile, and then the humeral head more superimposed over the rib anatomy. So here you can see it's in a true lateral position, the humerus superimposed. And right about there would be your under rotation. So you'll need to make sure that you rotate the patient further up. So let's go over the inferior axial projection. This projection results in a lateral view of the head and the neck of the humerus and the relationship of the humerus to the glenoid cavity. So the anatomy demonstrated, you want to make sure that you see the glenoid cavity, the proximal humeral head, the coracoid process, which you'll see here. The acromion of the scapula is seen here. And then again, that glenoid fossa is seen here. So for this projection, it's good to know that this is one of the best views for identifying both anterior and posterior dislocations, as well as Bankart lesions, Hill-Sachs defects. In order to get this view, this was obtained with the patient laying prone on the table. You elevate their shoulders, so it helps to bring the shoulder anatomy into the center of the image receptor. And you have the patient just lay prone with their arm off to the side, like in a neutral position, like you can see here. And then you're going to angle the central ray into the patient's glenohumeral joint space here to help open this up to get this area nice and open. Another way that this image can be obtained is with the patient laying flat on their back, and you have the image receptor placed here. The patient will rotate their head to their left. In this case, try to rotate that as far away from the image receptor so you can get this into their neck pretty far. And then what I usually have them do is reach their arm out as far as they comfortably can and have them hold on to a IV pole or something in the room. And then you're going to center the CR into the glenohumeral joint space. And then again, just make sure this is elevated. You can prop that up a little bit to make sure that the anatomy is in the center of the image receptor. When doing so, you'll see the coracoid sitting anteriorly. So, and then you'll have the open glenohumeral joint space. Both the superior and inferior glenoid margins will be superimposed. And then the humeral head is centered over the glenoid. The central ray is directed through the axilla towards the glenohumeral joint, which is seen here, and typically angle 5 to 15 degrees towards the patient's elbow, depending on the patient's anatomy. And it's also good to know in the axillary projection that the patient's arm is abducted approximately 90 degrees whenever patient conditions permit. So again, if they cannot get their arm out that far, then you may have to increase your angle so you can see the joint space more open. Be mindful though, if you are using a image receptor with a grid, that the more you angle, the more grid cutoff could be seen. So some common errors and fixes. Again, if the joint space is closed, you need to increase the arm abduction if possible, or adjust your CR angle to better align with the joint. If you see a distorted glenoid view, then that means you're using the incorrect tube angle. So you're going to want to recenter the X-ray tube through the glenohumeral articulation. Some exposure tips: the glenoid margins should be visible. So all of this area here and joint spaces should be clearly demonstrated. So the grashey view is another common shoulder X-ray that you may be required to take. So this projection is performed to obtain a true AP image of the glenohumeral joint, which is seen here, by aligning the scapular plane parallel to the image receptor. So unlike the standard AP shoulder, the goal is not to show the tubercles, it is to open the glenohumeral joint space. So in this, you're going to have the patient either laying supine or upright, whichever is more comfortable for the patient. You're going to rotate the patient between 35 to 45 degrees towards the affected shoulder. And it's going to depend on how much you rotate them based off the patient's body habitus. So if you have a thin patient, you're going to have less obliquity. So you're going to have about 35 degrees, an average patient about 40 degrees. And then if you have a heavier patient, more hyperstenic body habitus, between 45 to 50 degree rotation. So depending on that body habitus, that's going to determine the scapula and how it naturally lies, which is usually between 30 to 45 degrees anterior to the coronal plane. You're going to abduct the arm slightly, but keep the arm in a neutral position when doing a grashey view. The central ray you want perpendicular and then directed approximately 2 inches inferior and 2 inches medial to the superolateral border of the scapula, or of the shoulder, entering the glenohumeral joint. And then again, many departments simplify this by centering directly to the scapulohumeral joint. And our protocol, we're not required to get the entire clavicle within profile. For these projections, the main focus is this space here. So you're not really focusing on the greater or the lesser tubercle. Your main focus is this area here. So you want to make sure that you're getting that nice and open. So the anatomy demonstrated, again, you want to make sure that you're seeing this open glenohumeral joint space. You're going to see the proximal 1/3 of the humeral head. You'll see the coracoid process, the acromion, the scapular neck, as well as the lateral scapula in profile. So the evaluation criteria, again, make sure this joint space is nice and open. There should be little or no superimposition between the humeral head. The humeral head should remain centered within the glenoid cavity. No evidence of distortion from excessive rotation. The coracoid process should project slightly superior and medial to the joint. The glenoid cavity, you're going to see the anterior and posterior rims of the glenoid, and that should nearly superimpose, indicating a true AP of the scapula. The entire proximal humerus should include the surgical neck, the greater and lesser tubercle, and approximately 1/3 of the proximal humerus. Some common positioning errors: if the patient is under-rotated for a grashey view, the joint space may appear closed, so the humeral head may overlap the glenoid in that case, and the coracoid appears further away from the joint if you are under-rotated. So you're going to want to rotate the patient more towards the affected shoulder. For over-rotation, the joint becomes closed as well. The coracoid projects excessively over the joint, and the glenoid will become distorted. In order to correct this, rotate the patient slightly away from the detector. If you are using the incorrect central ray, that means that the joint is not centered, the superior or inferior anatomy may be clipped, or the joint may appear elongated. So to correct this, center directly to the glenohumeral joint space. If the patient is leaning from side to side, that indicates that the scapula is not parallel with the image receptor and that the joint will appear oblique. It will not be a true AP view of the scapula. And then that's what will cause the scapula to look distorted. So in order to correct that, just make sure that you have the patients rotated correctly and keep their shoulders and their thorax all in the same plane. So how would you evaluate the shoulder x-ray? Looking at the shoulder x-ray, I immediately think, okay, is this a left or a right? It looks as though it is a left shoulder. How do I know this? Because if I were to look at the patient, I'm looking as if they're looking at me. So if this is oriented correctly, this should be a left shoulder. Make sure when you are marking your films, you are marking them anatomically correct. In this case, I would make sure that the left marker is seen up in this corner out of the anatomy. This one, it looks like the centering is off. They have not included the entire shoulder, all of the scapula within the profile. So I would definitely open up the collimation. It looks like they're more centered here in this area. Maybe their focus was on the clavicle and not the shoulder, and they opened up the collimation. When looking at this, how do I know whether this was internally or externally rotated? Or maybe they were just trying to get an x-ray of a neutral shoulder position of the shoulder. How do you know? Again, let's kind of review again what we had gone over. If you don't see the lesser or the greater tubercle within profile, it means that the arm was in a neutral position next to their side. Again, make sure you are seeing the superior and the inferior angle of the scapula, which we do not see. So again, I would open up the collimation from top to bottoms to make sure that we are including some of that. In addition, I would also make sure that I am lowering my mask. This looks like it's too dark, but again, the centering is off as well. If the CR placement was more inferior, so 1 inch inferior to the coracoid process, then this image would be centered better, which would give us an overall better image quality and a diagnostic image. So it looks like the centering was more in this area here, more like the medial border of the scapula. Instead, we want to center 1 inch inferior to the coracoid process. So again, we want to just make sure that our centering is 1 inch inferior to the coracoid process, which is seen here. We want to make sure our centering is there. Overall, that would probably give us a better image quality, better diagnostic image, and overall better x-ray. The best shoulder image analysis aren't the people who memorize the positioning steps. They're the people who understand what the normal anatomy should look like and are able to recognize when something isn't right. Start using these evaluation criteria every time that you review a shoulder radiograph, and you'll improve your image critique skills, increase your confidence during clinicals, and be better prepared for the ARRT registry exam. If you found this video helpful with your shoulder anatomy, positioning, and image analysis review, be sure to like, subscribe, and leave a comment below telling me which shoulder projection is the most challenging for you. Master X-rays one at a time. Thanks for watching. See you in the next video.